He received his medical degree from Howard University in 2000, and his psychiatric residency was completed at Johns Hopkins in 2004. He's presented to the Judicial Institute of Maryland regarding issues related to the guardianship of patients with dementia, which again I know for some of us is an issue that's close to our hearts here. He's a native of Washington and lives with his wife and son in Olney. And he's an active member of Mensa, which I always find extremely impressive. So I will hand you over to a Mensa member.
Thanks. Thank you so much. Can everybody hear me okay? Okay. So today we're going to cover geriatric depression, and I've got a PowerPoint presentation, and I can be here as long as you need me to be, so if you need me to speed it up, let me know to speed it up. If not, I'll take my time. So we can go ahead and get started. And so we'll talk about depression in older adults, which is something that's underdiagnosed and undertreated. So here's a cartoon. At the bottom it says, I'd have been here sooner if it hadn't been for early detection. So, and this sort of illustrates concentration is impaired, and in the older patient population, which I probably should have defined at the beginning, that's everybody over the age of 25. So I guess that's everybody here. Okay. But specifically in the older population, memory problems can present as a symptom of depression. We'll talk a little bit more about that in a minute. Feelings of guilt, feeling worthless, anhedonia, a fancy medical word, which basically means you're not able to enjoy anything. You're not enjoying going out with friends, not enjoying your grandkids, your favorite TV show. And isolation, and we see a lot of that in the older population. They're in assisted living facilities. A lot of times I'll get calls for people, they don't want to leave their apartment, they're not coming down to meals. People may refuse offers to spend time with family or friends. They just really don't feel like being around other people. There's another cartoon. The clown saying, the x-rays indicate you are crying on the inside. So I like to show this cartoon because, I like to show that cartoon because there are no blood tests for depression. There are no x-rays for it. Sometime in the future we may have something more reliable in terms of a blood test or an x-ray or probably something along the lines of an electroencephalogram that sort of monitors brain function and brain waves. But as of now, depression, like most psychiatric illness, is a clinical diagnosis. So it's made by the clinician taking a history from the patient and or their family, examining the patient to sort of get a sense of what are the symptoms that the person is having, what are the, the degree of the symptoms, the severity of them, and the impact that it's having on the person's function, as well as the amount of subjective distress that the symptoms may be causing in the person's life. So I like to show that cartoon to say that we don't have the blood test yet. What we do have is this, which is the geriatric depression scale. And I did bring a paper copy of that, so Lynn may make some copies later for anyone who wants one. This is the short form. It's a 15-question questionnaire. And as you can see the questions there, you answer yes or no to the question. And some of the answers are in bold. And you see how many you circled that are in bold. Add those up. And the more that there are, the greater the chance that someone may have depression is. So the questions that are underlined, are you basically satisfied with your life? Do you feel that life is empty? Are you afraid something bad is going to happen to you? And do you feel happy most of the time? That's the super short form. That's for people who are very pressed for time. and that if you get bold answers for all of those 4 questions, the chance of having depression is pretty high. So this is, again, certainly not sufficient when compared against the full clinical evaluation by a professional, but it is a quick and somewhat reliable form that can be used by a professional, but also by anybody who's an individual to do an assessment, if they're wondering, do I have depression? A question? Sure. Sure. Yes. That typically in a depression we want to see symptoms beyond just the person says that they're feeling sad. That we would want to see evidence of perhaps sleep disturbance or appetite disturbance, concentration disturbance, guilty feelings, crying spells, thoughts of suicide. That sort of a lot of that is covered, actually most of those symptoms are covered in the questionnaire, and certainly a clinician would sort of take a look at the questionnaire and hopefully spend time with the patient to follow up and elucidate any of the positive answers to any of the questions. So this is basically, it's a screening tool. Just like sort of the PSA is a screening tool for the prostate. It's a simple, sort of quick and dirty blood test, and depending upon the results that come back, it can let a clinician know whether is further evaluation warranted or not. So preoccupation with physical symptoms. And then the last, cognitive impairment, which specifically we call a pseudo dementia. And what this is that the manifestation of impaired concentration in older patients with depression can be a cognitive syndrome that looks something like Alzheimer's disease, where they will be forgetful. They will have difficulty recalling things both from the past as well as currently. And that there's actually a chart, which I didn't put on here because the print is very small, but it sort of differentiates dementia from pseudo-dementia, and that it is a reversible condition, that if the depression itself is treated, a lot of times the cognitive impairments that the person presents with the depression will go on to improve as well. So oftentimes I will be called in. Dementia and depression, as we'll see in a little bit, go hand in hand, and that sometimes it may look a lot like a patient has Alzheimer's disease, but it may just be depression. So initially, usually I will treat the depression, and if cognitively they improve, then we have our answer. If not, then we need to dig a little bit further. So this cartoon is, yes, Oregon is lovely, but we're just here for the suicide. So I use this to illustrate the fact that the suicide risk in older patients is profound. It's 5 times higher than the general population. Some factors which may lead into this in the older patient population are things like loneliness, having health problems or pain, things like arthritis, financial problems, worries. Am I going to have enough money to last until I die? So there are additional challenges that getting older presents with us that may have something to do with the increased risk of suicide. Now, depression itself, it can also be a symptom of medical illness. So in patients who have stroke, about half of those patients will sometime, usually within the first 6 months after having a stroke, will go on to develop a full-blown episode of depression. Patients with Parkinson's disease, at some point in the course of the illness, again, about half of these patients will go on to develop a full clinical syndrome of depression. Hypothyroidism, so that's when the thyroid gland is not making enough thyroid hormone, a very common medical problem, easily screened for with blood tests. But if the person's not aware that they have it and are not having it treated, a low level of thyroid hormone can present with a clinical syndrome identical to depression. Dementia, as we mentioned a little while ago, can sometimes present initially looking a lot like depression and having significant overlap with depression. And certain types of cancer also seem to present, I don't think we quite understand why, but can present initially with a full-blown episode of major depression. Pancreatic cancer is one that is well known. Some types of lymphoma also can seem to present initially with symptoms of depression before the person has any recognition that they have some type of malignancy. Okay, so here is a picture of a nice young lady holding up a drink. So I think I would be remiss in my talk if I didn't touch on this next topic just briefly. So alcohol. Alcohol is a depressant. It depresses the brain. It slows down communication between neurons. That's why a lot of people like to drink it. It relaxes us. Most people, it tends to calm them down, disinhibits them a little bit, and makes them feel good, slows things down. However, some people can be very sensitive to the effects of alcohol, and people who consume a lot of alcohol, in addition to developing alcohol dependence, which I would point out is a disease in the same vein that depression is a disease or cancer is a disease. Oftentimes people who suffer from alcoholism will suffer from depression as well. And whether it's sort of the chicken or the egg is not quite clear. A lot of times people with depression will turn to alcohol to feel better because it will sort of provide for some folks a short-term relief of the sad or negative feelings that they have. And if you do that consistently, it may develop a depression syndrome of its own. I point out that alcohol used to be used as a medicinal substance. That if we think back to all the Civil War history books we've read or the movies that we've seen, that alcohol was used on the battlefield and after the battle as an anesthetic. That if you had to do a field amputation, you got the person stinking drunk, and it was an anesthetic. It was a numbing agent. And for a lot of people, it works very effectively for mental pain as well. And so it's worth pointing out, just something that, again, all clinicians want to consider, but it's something that's very commonly overlooked, especially by younger clinicians, I think in part because the idea of grandma or grandpa being an alcoholic is just unacceptable. But it is present even in those above 25. So it is something that we take a look at, as it may play a role in a particular patient's presentation with depression. Okay. So depression, as well as being a symptom of certain medical illnesses, it can also be a side effect of medications. So a statistic I like to point out is that most folks over the age of 65 are taking 4 or more medications. I'm not going to do a survey, don't worry, but most of the patients that I go to see, it's at least twice that to begin with. So, and there are a number of medications that are commonly taken which can have depression as a potential side effect. So, for example, narcotics. So these are pain pills, things like Percocet, fentanyl patches, codeine, that these are oftentimes given for intractable pain. So if someone has terrible arthritis that doesn't seem to respond to typical non-steroidal anti-inflammatory treatments, if the person has terrible migraine headaches, if they have a fall and break a hip and have post-operative pain, a lot of time narcotics are employed, and narcotics similarly can depress the nervous system. That can also bring about a syndrome of major depression. Anti-anxiety and sedating medications. So these are things like Xanax and Valium and Ambien that are very commonly prescribed by primary care doctors. Xanax is primary care doctor's best friend because no matter what the person comes in complaining of, 9 times out of 10, Xanax will seem to make it better, at least in the short term. That being said, a lot of the anti-anxiety and sedating medications function in the brain a lot like alcohol. They slow the brain down, they relax us, can maybe disinhibit us. And similarly, just like alcohol, depression can be a potential side effect from these medications. Antihypertensive, so medications for high blood pressure. Certain of these drugs, certain classes of these drugs have been associated with depression. Again, they have different mechanisms by which they work, but most of them do seem to impact the nervous system somewhere, whether it's directly affecting the innervation of the smooth muscle that lines our arteries, or whether it's like clonidine, which is more of a centrally acting antihypertensive. Again, it's designed to kind of bring things down and can bring people down too. So, chemotherapy drugs. So patients who are undergoing treatment for cancer, certain chemotherapy agents have depression as a side effect of them. Certain immune modulating agents as well. Interferon is one that maybe some people may have heard of, that's used commonly. A large proportion of people who get interferon seem to get depression, and it does seem to be independent of having cancer. And certainly, one could imagine, well, having cancer certainly could be depressing, but when they take a look at those with cancer who are treated with certain agents and those who aren't, the ones that seem to have depression as a side effect, it does seem to be a legitimate and a real effect, independent from being depressed about having an illness. So, and then last but not least, steroids. We're not talking about anabolic steroids for bodybuilding, but more the corticosteroids, progesterone derivatives, that are oftentimes used to treat inflammation and swelling. I think they're very commonly prescribed, probably second place right after Xanax, because if you've got an ache or a pain somewhere, or an itch, steroids are going to take care of it. But steroids can have effect on mood. They can seem to initiate episodes of depression. Interestingly as well, in some patients who may have a predisposition to having manic depression or bipolar affective disorder, steroids can sometimes trigger them into having a manic episode as well. So it is something that we use with caution. Gout medications, indomethacin is one commonly prescribed for gout. I don't know if anybody here has ever had gout. I've heard it's horrific. Indomethacin is effective for it, but depression is a potential side effect of that as well. So here's a folk singer, and this is a sad little blues tune about love and pain I wrote before I started taking Celexa, which is an antidepressant. So we're going to talk a little bit now about treatment. And I probably should have said this at the beginning, but if there are questions, you can jump right in, or if you want to, have questions for me at the end, I'm happy to stay as long as you want me to. So as I mentioned in one of the earlier slides, that only 1 out of 10 older patients with depression is getting any kind of treatment for it. So psychiatric services are underutilized across the board, but in the older patient population as well. Why is that? Primarily it's because of stigma. That because for the longest time depression didn't show up in a blood test or an x-ray, you couldn't see it, smell it, hear it, taste it, feel it with your hand like you could with most of the other medical diseases. I mean, in the old days. One of the ways diabetes used to be diagnosed was they would take a urine specimen from a patient and the doctor would taste it. And if it was sweet, diabetes. So that's why I say if you can't see it, smell it, hear it, taste it, swallow it. You know, if it doesn't show up on a blood test or an x-ray, it's thought to not be a real disease. We know that that's not true. However, that has been sort of a incorrect pattern of thinking that I know the psychiatric community has been fighting against for a long time. So in part, stigma is one of the reasons why only crazy people go to see a psychiatrist. I'm not crazy, I'm just bummed out. There's a belief that depression it's just a matter of willpower. You know, if he wanted to feel better and get out of the apartment, he would. Sort of the false beliefs, or I guess the misinformation. The cost of medication. I've heard antidepressants are expensive. Co-pays for going to see a psychiatrist, and the difficulties getting in to see a psychiatrist, which only recently changed. It used to be that oftentimes patients would have to get approval from their physician before the insurance would agree to pay to visit with a psychiatrist. That thankfully in theory has changed, but it can be a pain in the neck, it can be difficult, it can be a challenge, and on a good day some of us don't want to deal with stuff that's a pain in the neck, nonetheless when we're feeling depressed. This idea that depressed people were crazy and crazy people go to the asylum, that some people will have in their family or will know someone who had in their family someone who got sent away to the asylum. And before the 1950s, before we really started to have medications or other treatments for depression and other mental illnesses, a lot of people did go to sanitariums where a lot of people did get better. But again, it wasn't talked about. Aunt Sally got sent away. So that belief that if you're crazy, they're going to send you away. And then last, the belief that it's not socially acceptable to discuss your feelings. We see this much more in men than in women, who seem to be more comfortable discussing their feelings, but especially men. Men don't cry. We're not supposed to be soft like that. We're not supposed to say that we're hurting or feeling sad. So that belief that men just don't do that. So thankfully, depression is very treatable. See, there's good news. And here we've got an ad for Prozac, mood brightener, wash your blues away with Prozac. So there are some very good treatments that can be very effective for depression. We have antidepressant medications. You don't need to memorize these. There's not going to be a test afterwards. But SSRI stands for selective serotonin reuptake inhibitors. So these were medications like Prozac and Paxil and Zoloft, which have been around since the 80s. SNRIs are selective norepinephrine reuptake inhibitors. These are medications like Cymbalta and Effexor, and they're a little bit more recent. They've only been around probably the past 10 years or so. And then bupropion, which has also been around a long time, also called Wellbutrin, initially came out as a treatment for helping people quit smoking. And it seemed to be effective in helping them not be so irritable when they quit smoking. And then they said, if it helps irritability related to quitting smoking, maybe related to depression too. And seems to be effective. So tricyclic antidepressants. So these are older medications. They came out in the late 60s and the 70s. Medications like Pamelor and Elavil was a very popular one. The generic names were things like nortriptyline and imipramine. Very good antidepressants. In the older patient population, we use them a little bit cautiously because they can cause orthostasis, which is a fancy medical word basically meaning that when you go from lying down or sitting to standing up, your blood pressure drops a little bit. And that can make you dizzy and can make you fall and hit your head or break a hip, so we don't like that. So we don't use them a lot in older patients who can be a little bit more likely to have those side effects. Similarly, the tricyclic medications can have an impact on cognition or memory. So if a patient is presenting with depression and they're having some memory issues, we wouldn't want anything to confuse the picture or make things worse. The MAO inhibitors, or the monoamine oxidase inhibitors, if anybody has ever filled a prescription, most likely the little blurb that you get with the medication from the pharmacy probably says, may cause all kinds of side effects, and whatever you do, don't take it if you're taking an MAOI, which is a monoamine oxidase inhibitor. These were some of the very first antidepressants and are actually very effective. They're a pain in the neck because they can have a lot of side effects. They can have a lot of interactions with other medications. There can oftentimes be a need to have dietary adjustments. You're not supposed to eat soy products, which are pretty much ubiquitous in food these days. You're not supposed to have sauerkraut, pastrami, cured meats. So a lot of people, I've had patients say to me, if I can't have a corned beef sandwich, I'd rather be depressed. So, so these are generally not used often, but they can sometimes be helpful, especially if patients have Parkinson's disease. They can help that as well. So we will use those very cautiously and judiciously from time to time. And then we have stimulant medications. So these are medications that are often prescribed for attention deficit and hyperactivity disorder, what they used to call ADD. And they can be very helpful with attention, but they can also help with one of the components of depression, which is motivation. They can be somewhat motivating. So stimulants are sometimes used if a patient is presenting with a very apathetic, amotivated sort of depression. They can have a lot of utility there. We do need to use them cautiously because of hypertension. So stimulant medications, they can stimulate our mood, but they can also stimulate our blood pressure to go up. So we need to keep an eye on that. And anorexia, not in the eating disorder sense of anorexia, but anorexia in the medical sense, meaning lack of appetite. So stimulants can decrease appetite. They were very popular in the 1950s for just that effect. They were housewives' helpers. They'll keep you looking trim and give you tons of energy to, do the things you're supposed to do when you're a 1950s housewife that, culminates with having a martini for your husband when he comes home. So electroconvulsive therapy, or ECT, what are oftentimes called shock treatments. These are one of the older forms of treatment for depression. That this was what we had before we had antidepressant medications. Electroconvulsive therapy is still used today and is an extremely effective treatment for depression. That it is nothing at all like anything you have seen on television or in the movies, where people are strapped down and are zapped in the head with electrodes and are flopping around on the table. It's done in a hospital. The person receives anesthesia, the same as if they were going to have a medical procedure, so they are asleep. They receive a mild shock. It induces a seizure, and you can tell the person is having a seizure because their little toe is wiggling like this. There's no thrashing around, and the brain waves are being monitored, so you can see when the seizure ends. And the seizure itself is thought to be what is therapeutic. We don't quite know why, but sort of the best analogy I can give is it's sometimes like maybe when your computer's on the fritz, if you just kind of turn it off and reboot, sometimes that fixes the problem. Before electroconvulsive therapy, it was initially started with something called insulin shock therapy, where patients would be given large doses of insulin. Their blood sugar would drop way low, and that when your blood sugar drops extremely low, you have a seizure. So they would clinically induce seizures that way. Unfortunately, not the safest way of treating folks, and that there were some patients who died. So they said, let's come up with some newer ways of inducing a seizure, and electricity It's still done today, and oftentimes for refractory cases of depression, but it is extremely effective and fast. So for those that were driving initially on the depression highway, so that's the lane for Zoloft, that's the lane for Prozac. Those who are currently on Paxil there. Looks like a lot of those are in New Jersey, which is enough of a reason to be depressed, I suppose. No offense to any Jerseyites that are here. Please.
Excluding electrotherapy.
Sure, very, very good. So the question was, how is it that a clinician will choose which particular treatment to use with a patient? I can't speak for everybody, but I can certainly say how I do it. Is I do a very thorough evaluation. I take a good look at what are the other medications that they're taking. I take a good look at what medical conditions do they have. Do they have a seizure disorder? Do they have glaucoma? Do they have high blood pressure, heart disease, migraine headaches? If the person has received a treatment before for depression, what have they received? How did they respond to it? Did it help? Did it not? Did it cause a side effect? If so, which one? So I take a good look at that set of data, and then I take a good look at the particular symptom presentation that the patient comes in with. So for example, if a patient comes in and they are depressed, and one of the manifestations of the depression is insomnia and irritability and lack of appetite, there's a medication called mirtazapine, which has the trade name of Remeron. And in addition to being an effective antidepressant, one of the side effects of Remeron is it tends to make people tired, so that addresses the insomnia. It can make people hungry, so that stimulates the appetite. And the antidepressant effects will treat the irritability that's coming along with the depression. On the other hand, if you have a patient who's hypersomnic, who's sleeping all the time, who has a lot of apathy, and just doesn't have any motivation, well, a medication like Wellbutrin, which is more of a stimulating antidepressant, that may give them, in addition to treating the sad feelings, may give them a little bit of pep, a little bit of energy, a little bit of get up and go. So I try and match up as best as I can the medication profile in terms of side effects and the particular symptom cluster that patients are presenting with. Always taking in mind, I don't want to start a medication that's going to somehow impact the metabolism of another medication, or is going to cause some kind of reaction. Or if the person has high blood pressure, it's not well controlled, I might not want to start Wellbutrin because that can elevate blood pressure. So that's how I do it. I think that's how most clinicians do it. Is that a good answer?
It's terrific.
Good. Okay. If you ask a question and the answer is not satisfactory, ask me again a different way. I don't mind. Okay, so outside of medications and electroconvulsive therapy, there's another side of treatment that is just as important. And these are things that we call them the talk therapies or the psychotherapies. Every New Yorker cartoon with a psychiatrist has somebody, a patient lying on a couch, talking to the psychiatrist who always seems to be bald and sleeping. But talk therapy is a very important part of treatment of depression, and oftentimes it can be the entry point where some people may feel more comfortable speaking with a psychologist or a social worker. They might not feel comfortable with taking medications, and oftentimes they will start some talk therapy, and if after a while the therapist feels, I think we need some help in the talk therapy, I think we need some medications to give things a boost, they may then refer to a psychiatrist. So talk therapy is a critical and crucial part of a holistic treatment of depression. And there are lots of different flavors of talk therapy. You can have supportive therapy, where the therapist is generally empathizing a lot with the patient, helping to normalize their experience and sort of support them until they start to feel better. Sometimes the therapy is helping connect patients to resources. If the person is just overwhelmed and having difficulty managing their finances, if the person has stopped driving and needs someone to go to the grocery store, that some types of therapy are very much sort of connecting them with the proper resources to receive the treatment. That can be extremely helpful. Group therapies, sharing the experience, recognizing that as lousy as you feel, there are other people who feel lousy. There is something for the saying, misery loves company. So group therapy, so whether it's a grief therapy for someone who's lost a spouse, whether it's an illness group for individuals with cancer or Parkinson's disease, sharing the experience, typically with a psychologist or social worker who's sort of leading the group, profoundly helpful. Cognitive behavioral therapy. This is, I would say, a newer form of therapy. It's been around since the 60s, but sort of is somewhat different from the typical more analytic Freudian therapy that we think of that's always portrayed in cartoons. And this is really taking a good look at the particular thoughts that an individual is having and trying to analyze the thoughts to see, is this an exaggeration here? Is there a different thought that we might substitute that might be more realistic? And that the great philosopher and social critic and comedian George Carlin was one of my first professors of psychiatry when I was a young child, and what he taught me is that words are important because we think in words. And if you can control the words that someone uses, you can control their thoughts. And this is a place where that is used not so much as an advertising, but is sort of used for the force of good, so that when someone says, oh, that was stupid of me, you sort of help them understand, no, don't say that was stupid of you. Say, I'm a smart person, but that wasn't a really good choice that I made. It describes the same behavior. It gives an adequate description, but it's not pejorative in the way. And that when we analyze the words that we use to describe ourselves and to describe our experience and behavior, if you substitute happier words, you'll probably feel happier. So cognitive behavioral therapy basically teaches patients how to do this, how to analyze their thoughts, how to substitute more realistic thoughts, how to tell if their thought is an exaggerated, unrealistic one, and can be very helpful. And insurance companies like it because it's generally a time-limited therapy. So interpersonal therapy. So this is analyzing relationships that people have with one another. And is an older person depressed because they don't have a good relationship with their children or their grandchildren or their spouse after 45 years of marriage? Problem solving, just very clear, concrete, here's how we solve this problem. Profoundly quick and profoundly powerful. And last but not least, psychoeducation. So going somewhere, speaking to a professional who can educate you about mental illness like depression, who can teach you that it is a true disease, that it is treatable, and having that understanding. So coming somewhere like here and listening to someone like me. You've already been participating in psychoeducation. I will be collecting insurance information and billing everyone afterwards appropriately. So I like to show this at the end of talks. So this is an ad for a medication called Thorazine, which is one of the earliest psychiatric medications. Initially was used to treat schizophrenia. It's a powerful antipsychotic, but this was an advertisement in a medical magazine for doctors. So think Thorazine for prompt control of senile agitation. So here's a a spry young man holding up a cane, getting ready to whack somebody in the head. So this is usually what gets my phone ringing. So, but I've never had anyone actually hit me with a cane, but I've had a couple people try. So I think that's the end. Yep. So I am happy to stand up here and answer as many questions as you have. If you prefer to approach me afterwards one-on-one, I'd be happy to speak with you that way as well. So question there in the back?
Well, this may be fairly naive, but I noticed that you didn't, unless you did it before, I thought you didn't know anything about physical exercise.
That is not naive at all. Absolutely. So the statement was observing that I did not mention the role of physical exercise, and you are absolutely correct. I did neglect to put that in my slides. I will correct that. I'll come back next year. I'll give the talk again. But you're well, it would go under treatment. It could also go under prevention, and that I did not mention, but as you pointed out. Physical exercise can have a profound impact on the treatment of depression. Now, generally, the studies that have been done show that it generally needs to be very vigorous exercise, and it needs to be at least 30 minutes or so, 3 times a week, and sort of get the heart pumping about 3 times its resting heart rate. That is something that a lot of doctors are not comfortable recommending that their patients with arthritis, heart disease, and high blood pressure do on a regular basis. I would never want to be accused of ageism, but I find a lot of the patients that I'm working with, I certainly recommend, sort of being active and being, stimulated both mentally and physically as much as they're able to. I may be a little bit biased in that a lot of the patients that I see are in nursing homes and may have walkers or wheelchairs, so getting them to do vigorous enough exercise to have an antidepressant effect is something I don't see often, but you are absolutely correct that for those who can, exercise extremely beneficial for multiple things, not just depression.
Well, just to follow up on that question, though, but what about just activity that isn't that strenuous, but it's fun and reduces stress?
Absolutely.
So wouldn't that,
Well, it can be helpful. Yeah, again, if you're sort of, certainly we would look at that to be prophylactic, but a lot of times, when patients are in a true clinical depression, the isolation, the amotivation, just the difficulties that they have getting the motivation to do the activity. So I can't tell you how many patients I treat who are in assisted living facilities who it's like, there's a bridge game, just take the elevator down, you like to play bridge, it'll be good for you. And they just can't seem to get themselves to do it. So it can sometimes be a little bit of a catch-22. I almost got into a fight with a guy in a bar last weekend, and that he was talking about his sister-in-law who has depression, and she just needs to, get her lazy butt up off the couch and jog, and that will solve her problems. And I said, well, she can't. She has depression. It's an illness. It's affecting her. Well, it'd be better if she just, and I said, you've never been depressed, have you? He said, no. So, but yeah, it can be very tough. It can sometimes be a catch-22 to sort of get the person motivated to get going. But if you can get them started, sometimes you can, pick up some momentum, and it can help.
You had a statistic up there about the high rate of suicide among men over 85. Mm-hmm. And what came to mind was the fact that, every once in a while you read in the newspaper about an older person who takes his or her own life, or maybe even a kind of murder-suicide situation with a couple. And I'm wondering if that is always a situation where depression is evident, or is it more of just a willful
Sure. Sure. That's
a
a
decision that is not about having depression.
sure. No, that's a very good question. The question was to sort of condense it a bit. Is everybody who kills themselves depressed? Could there be a reasonable or rational explanation or reason for someone to have, to take their own life? And the answer is no. Not everybody who commits suicide is depressed. However, the statistic, I give a talk on suicide as well, so I know the statistic. 95% of people who commit suicide have an untreated mental illness. So that having a mental illness is definitely a risk factor for suicide. Depression is very common, but it's believed that up to 10% of individuals who have schizophrenia 10% will commit suicide. Bipolar disorder may be even more prone to committing, individuals with bipolar maybe more likely to committing suicide than those with depression. Substance abuse is a huge contributor, that it's felt that up to perhaps 50% of people who commit suicide, substances are somehow involved, whether they have an addiction to a substance, whether the substance is used as the method of committing suicide, such as an overdose, or whether something like alcohol is used as liquid courage to disinhibit them. So the answer to your question is not everybody who commits suicide, it's because they're depressed. But the overwhelming majority of people who do, it's because they have a mental illness, most often one that's not treated. Suicide is also something that is profoundly underreported, that the numbers of suicides that occur have been speculated to be 2 or 3 times greater in individuals than what we actually know about. That the question of quote-unquote accidental death, or certainly, again, coming back to the shame and the stigma that can be associated with having a mental illness, the stigma of having someone, committing suicide, that sometimes he was cleaning his gun and he accidentally shot himself. She was cleaning the window and she accidentally fell out. He was taking a view from the Golden Gate Bridge and he accidentally fell off with the suicide note in his pocket. So the actual numbers of suicide are much higher than probably we know. But there are certainly circumstances, and I was actually at the American Psychiatric Association convention last week and sat in on a seminar looking at how to differentiate suicide from a desire for hastened death in patients on hospice. And that there does seem to be a difference between the two. And certainly all of us can empathize if we were 90 years old and we had terrible arthritis and we couldn't drive and we couldn't walk and we couldn't see and we couldn't hear and we were in agonizing pain. Yeah, punching out might seem like a better option than waking up tomorrow. We can certainly empathize with that. So.
Do you have handout? Because my handicap is bad hearing and forgetfulness.
Okay. Well, what I can do is, if you want, I can make a copy of the presentation. I did bring a couple of handouts. One of them is the mood scale, the one that I showed up there, which is the 15 questions, sort of a quick look to see, to screen for depression. And then the other handout I brought is a series of resources for depression. So I put the contact information for the Washington, D.C. Psychiatric Society, the National Alliance for the Mentally Ill, or NAMI, the American Psychological Association, the American Association for Geriatric Psychiatry, and the Depression and Bipolar Support Alliance. So I have both of these, and I'll give them to Lynn, and then she can make copies and distribute them to whoever wants. But I'd be happy to make a copy of the slides and get them to you if you like. Okay.
The 95% figure, is that for all people who commit suicide or for elderly people?
That's all people. You know, sort of a general, yeah, not age-related, but 95% of people who commit suicide. Because a lot of people commit suicide before they become over the age of 65. So.
If you're okay with sending me the slides.
Okay.
Yeah, I can share.
Sure.
I want to know if you could talk a little bit more about the relationship between anxiety and depression.
Sure.
Can a person just be high anxiety and not depressed, or depressed and not anxious, or do they always come together?
Sure. So the question was about the relationship between depression and anxiety. I'll put it this way. The DSM, or the Diagnostic and Statistical Manual, which is sort of the checklist book that is sort of used to diagnose mental illness. They have a condition called major depressive disorder with anxious features, and they have something called generalized anxiety disorder with depressed features. I'm a Menson, but I don't know the difference between the two when they walk in my office. Depression and anxiety oftentimes will go hand in hand. And especially in older patient populations, hypochondriasis can be a particular symptom that we see along with depression. So not everybody who's depressed is anxious, not everybody who's anxious is depressed, but a lot of times they go together hand in hand. The treatments for anxiety are almost identical to the treatments of depression. That the term antidepressant, when referring to a medication, is a bit of a misnomer. Because antidepressant medications are also the first-line treatment for the medical management of anxiety as well. So a lot of times they do go hand in hand. So, other questions? Okay, if anybody else has a question, wants to approach me afterwards at the end, I'd be more than happy to stay and chat with you.
On behalf of the board and our members, thank you very much.
Oh, my pleasure.
Very interesting.
Thank you.